be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. We're thrilled to have you all watching from hopefully your own comfortable living rooms. Tonight, as you guys may or may not know, is the much anticipated annual Best of ASCO Living Room. We're going to be talking tonight about some of the exciting things to come out of that meeting, and most importantly about how research isn't stopping and progress is still happening. So welcome, welcome. I'm Danielle Hicks, for those of you who do not know who I am. I oversee patient support services here for GoTo Foundation, and I'm thrilled to be able to bring you this wonderful conversation we're going to have this evening with our very own Amy Moore, PhD, who's the Director of Science and Research at GoTo Foundation, Jorge Nieva, who's the Associate Professor of Clinical Medicine at the University of Southern California. So welcome, Dr. Nieva and Amy. It's thrilled, like I said, to have you guys here. 10 or 11 years ago, when I went to my first ASCO meeting, you were hard-pressed to find anyone with anything in their pipeline for lung cancer, and now you're hard-pressed to find anyone who doesn't have something for lung cancer in their pipeline, which is very exciting for us and for our community. We're going to talk about some of the exciting stuff coming out of this meeting. And for those of you who may be new, ASCO is an annual meeting. It's the American Society for Clinical Oncology, where research that has been going on is then presented, the data and the findings are presented at this meeting. So this is really a meeting all about discoveries and exciting things happening across all cancers. Obviously, we're going to be focusing on lung cancer. And tonight we're going to put these in sort of some buckets. The first bucket is going to be around some of the things that are happening with early stage lung cancer. And then we're going to talk about targeted therapies, some new targets and what's going on there. Obviously, we're going to talk about immunotherapy, because what would a lung cancer living room be if we weren't talking about targeted therapies and immunotherapies in some form or fashion. And then we're going to talk a little bit about COVID and lung cancer. And between ASCO and then a meeting that Amy's been attending since Monday, I believe, Amy, it started, the AACR meeting, talk a little bit about some of the data that's coming out around there and what we're learning in that space. But first, I want to point to you, Dr. Nieva, and I want to talk about the ADORA trial. So this, for those of you, again, is some exciting things that are happening in this early stage lung cancer patients. So can you talk a little bit about what the ADORA trial is, what was the purpose of the trial, and why this is an important patient population to look at?
Well, this was a very exciting study. You know, when patients have advanced lung cancer, stage 4 lung cancer, we get very excited about differentiating the molecular subtypes. We have a different treatment for every molecular subtype. But still, when it comes to earlier stage lung cancer, stage 1 through 3, lung cancer that's treated primarily with surgery, we still have a paradigm that everybody gets treated the same way, and they get treated with chemotherapy. And the ADORA trial is a very interesting trial in that we're now looking at using a targeted therapy in early stage disease and seeing if it made a difference. And boy, what a difference it made. We found that by taking patients who had EGFR mutations with early stage lung cancer and treating them with a targeted agent, osimertinib, and doing that for up to 3 years, we had very few relapses. I mean, the chance that you would relapse was like 17% of the probability that you would relapse if you didn't get the therapy. So that was the great news. And that was really what was very exciting and practice changing about the ADAURA trial. But of course, with every advance that happens in lung cancer, we always have this initial burst of excitement and then a little bit of reality that we don't have all the data yet. And what we don't know is whether or not when targeted agents are used in early stage disease, is it preventing relapse or is it just delaying relapse? And if it's preventing relapse, then of course this is one of the greatest clinical trials in lung cancer that's been done. But if it's only delaying relapse, then it just means that we're treating more people earlier than perhaps needed to be treated. And we could just apply the same therapy later if all we're doing is delaying. And we're going to get the answer to that question in a couple of years once we have more mature information on the people that were enrolled in the study. But again, the early numbers really look very, very good. And I think for a lot of people, practice changing.
Yeah, and I think, can you talk a little bit about how this affects biomarker testing and who is, currently being tested, and if the data shows what we hope it's going to show in this earlier stage population, what that will mean for who's actually getting tested?
Yeah, well, that's critical because right now I think many insurance companies, many providers are really only testing late stage patients because we really haven't had anything to offer to do anything different for early stage patients. And I'm a big fan of early testing. I think we need to know early on what people have, if nothing else, so that we can direct them to the right clinical trials, because there are lots of clinical trials like ADAURA, other ones out there in the community, like the Alchemist trial and a few others that are out there, where we're treating early stage patients differently on the basis of molecular profiling. But of course, we can't find out who those people are unless we do good comprehensive molecular profiling in early stage disease. And of course, it's the early stage patients, the ones that have surgery, where we have the biggest amount of tissue to test. And so they're the ones where testing has the highest yield in many ways.
Right, and quite often where the testing is not done, right, because the data hasn't shown that there's a reason to yet. Amy, I don't know if you have anything to add. I know that at GoTo, this is a space that's near and dear to our hearts, with wanting to really increase screening rates for patients and biomarker testing. Do you have anything you want to add to what Dr. Nieva said?
I mean, I think, there are obvious pluses, and the community is very encouraged by the results, and rightfully so. I think we have to proceed carefully because of the unknowns, right? We're talking about disease-free survival currently. We don't yet know overall survival. So there is that caveat, and that's been debated and discussed kind of at length in various formats and venues. We have to weigh impacts on quality of life. We have to weigh impacts and concerns about financial toxicity, access for those who may not have insurance. We know that, outside the U.S., access to drugs such as osimertinib are still a challenge. So there are all those things that the community has to grapple with. But I think the point is well taken that, comprehensive biomarker testing early at the point of diagnosis is critical for the best outcomes for patients. And that is a core pillar of GoTo's mission and what we want to achieve. And, I think the lung cancer community is kind of coalescing around this, the importance of comprehensive biomarker testing, timely testing. And, that's something that we will continue to push forward on, especially in the context of this study.
Thanks, Amy. Dr. Nieva, I have a question just based on some personal experience through talking with patients that will call the foundation looking for support or guidance in some form or fashion. And, we've had patients in the past who were surgical candidates who did have surgery and then did unfortunately recur. To those who might be watching this that are asking the question, well, why didn't they test my tissue when there was a lot of tissue, because now I either have to go back in for another biopsy because that tissue is no longer available. What is your sort of what would you say to that patient?
I'd say that typically tissue is held on to for 7 years. So if you did have surgery and you relapse in the first 7 years after surgery, that tissue is available to the hospital. They may have put it in storage. It may not come very quickly, but it is available and you can do testing on it. And I would encourage you to make sure you exhaust that before you go down to have another biopsy done, another procedure, and all the risks that go along with that. But if it really is gone and, it's a late relapse, it happened more than 7 years ago, or for whatever reason your tissue's not available, let's say you had surgery in another country or something along those lines, then you just have to have a biopsy and you have to have testing again. Now you can do testing with both blood and with tissue, and we know that there's about an 80% concordance with those two. So if it looks like it's going to be difficult to do a second biopsy, you can do it with blood, and that's an option. But up until this point, I think many insurance companies have been very reluctant to test early stage patients because there wasn't an immediate decision point that you would make. Again, we would treat them all with the same treatment after surgery, either chemotherapy or radiation. It's never been biomarker driven before. But because of exactly what you said, I encourage all patients to get biomarker testing early on, when they have that first tissue, so we have that information available. So if there's someone out there who's, about to have surgery or just had surgery recently, getting that testing accomplished so that you have a report and you have it in your hands so you know what to do if you have a recurrence, I think just provides a lot of mental health benefits. Nobody wants to be told, oh, well, we'll do a biopsy and then we'll send off testing. And maybe a month from now, we'll know what the right thing to do is. Nobody wants to wait a month. If you have your testing already done early in the disease and you do relapse, and unfortunately, the majority of the patients are still relapsing after surgery, depending on the stage, not so much with stage ones, but with stage threes after surgery, then if you already know what your molecular profile is, then when you do have a relapse detected, you instantly know what to do.
We know that obviously the academic centers for sure are keeping these tissues. Some of the larger cancer community centers are keeping the tissues. Some of the smaller centers, particularly in the more rural areas, don't have the capacity. So it's definitely worth a conversation with your surgeon prior to surgery if it's something you want to explore the option of. For those of you who may want to have more information about surgery, some of the things that we're talking about that may have been a little bit confusing, we have our lung cancer living room video library where we've got living rooms specific to surgical options, or of course you can call our helpline and we can help you with that. So if nobody has anything to add on the ADORA trial, any more points? Oh, yeah, please.
Yeah, I was just going to jump in and just reinforce the point. And I think Jill Feldman did a great kind of personal discussion of this from her vantage point of a family history of lung cancer and her own personal experiences of going on adjuvant TKIs, and the value of shared decision making in this conversation, and that dialogue between provider and patient, and kind of understanding what patients' needs and concerns and goals are is an important part of this overall discussion. And we already have heard anecdotes of some patients whose doctors have put them on on the DORA study in light of the results presented at ASCO. So, I don't want to, forget the importance of the patient and their voice in this discussion.
Thanks, Amy. I couldn't agree more. You're preaching to the choir, that conversation in the patient's voice, and asking them what their wants and needs and goals of treatment are such a huge part, and really letting them weigh out all their options to your point. So thank you. In addition to ADORA, several presentations focused on advances in targeted therapy, describing some new and some additional options for many different biomarker positive lung cancers. So I want to discuss some of the data next, specifically in HER2, MET, and RET. But Dr. Nieva, before we jump into those three subsets, can you talk a little bit about what a biomarker positive lung cancer is, or what it means for those who may be new here?
Sure. Well, back when I was in my training, there was two types of lung cancer. There was small cell and non-small cell, and that's all you really needed to know. And the treatment programs were the same for both. But now, in the molecular genetic era of medicine that we're in, we have the ability to test the cancer for various genomic alterations. And those genomic alterations are actually quite common in lung cancer. They're particularly common in people who have light smoking histories. They're particularly common in women, common in certain ethnic groups such as Asians. And so we find that many lung cancers are driven by these oncogenes that we can identify. And if you turn those oncogenes off with a drug, you get results that almost always are better than what you would get with chemotherapy. So we can identify the driver oncogene of lung cancer now in over 60% of cases. And having specific drugs that can treat them is really terrific and really highly effective. The oncogene targeted drugs are generally less toxic than chemotherapy, and they work. And so that's great. And so, the first oncogene that was really important was the one that we described in the ADORA study, the EGFR gene. But of course, now we have targeted therapies available for 8 or 9 different oncogenes. And some of the other papers that came out of ASCO really gave us insights into some new drugs that are targeting specific oncogenes that aren't very common. Oncogenes like ERBB2 that affects, around 4% of lung cancer patients, or MET, which is, somewhat similar, and RET, which is another couple of percentage of patients. But, when you add up all these little small percentages, eventually you find that lots of people benefit from oncogene-driven therapy.
Thank you, Dr. Nieva. Amy, do you have anything you want to add?
No, I think, again, the pace with which we've seen these new drug approvals throughout the spring of this year is just breathtaking. And I think is a point that the lung cancer community can take great hope and encouragement from. For those of us in the field, it's almost been a challenge to keep up. And that's a good thing, right? Because they're coming so fast and furious. And, as Dr. Nieva said, for those targeted mutations, it's very encouraging that we continue to kind of define new slivers of the pie and have new options available. And that, again, is where, GO2 Foundation has our Lung Match team, a dedicated team of PhD and master's level scientists who can help navigate patients to these new drugs and new trial opportunities, and that's something that I encourage everyone to take advantage of, and it's a great resource to help you wade through all these new options that are out there.
Thank you, Amy. I just want to reiterate before we jump into some of the data findings from ASCO in a couple of these different spaces, that these targeted mutations or oncogenes, they go by many a name, biomarkers. The only way to find out whether or not you have what at the bottom line could potentially be driving your cancer is through the biomarker testing that we were talking about just a couple of minutes ago that Dr. Nieva pointed out is done either with tissue or even more recently with what they're calling liquid or blood biopsies. So I just wanted to kind of reiterate that point and kind of make the biomarker testing, targeted therapies connection. So with that, let's jump into HER2, which I think most people, if they know anything about cancer, have heard HER2, but they've heard it historically when it came to a breast cancer, right? So what role does HER2 play in lung cancer, and what was some of the data that came out in this space at ASCO?
Well, yes, HER2 is commonly mutated in patients, and by commonly, we're talking about 5,000-10,000 people a year in the United States. So it is a significant number of people that have this abnormality, and it's a little bit of a different molecular problem than breast cancer. In breast cancer, it's that the cancer makes too much. Whereas in lung cancer, it's usually that the gene is actually broken and mutated in the tumor cells themselves. Now, you can't be born with this abnormality. It has to be acquired inside of the lungs. And at ASCO, they presented data on a new drug, which is called Enhertu. And the generic name is one of these awful long generic names. It's trastuzumab deruxtecan. And this drug works. This is a drug it's a protein that brings chemotherapy to the site of the cancer, and then the chemotherapy then goes right to where the cancer is. Now, this is the second drug that has become available for patients with lung cancer and ERBB2 abnormalities with the same mechanism. It's what's called an antibody drug conjugate. The antibody is an immune protein that targets the cancer, and then the chemotherapy drug kind of floats off. And the great thing about this strategy is that the tumor sees lots of chemotherapy and the rest of the body does not. So relatively mild side effect profiles for this class of drugs. And this drug works. Now, we know from the breast cancer field that even patients whose cancer grew on the other antibody drug conjugate that's out there, which is Kadcyla, patients whose cancer grew on Kadcyla will sometimes see their cancer shrink on Enhertu. So it's great to have multiple options for our patients, and this is yet another option for patients with this rare tumor type.
This is great, and it's something that we're definitely seeing trending in the whole drug space, where there's more than one drug per target, if you will. So that's really exciting for HER2. What about MET? What's going on in MET? MET's been around for a while without a lot of things happening to it, and now all of a sudden I feel like I'm hearing about MET and RET all over the place. So talk a little bit about that.
Well, MET is another kind of small percentage oncogene, present in, maybe 4 or 5% of tumors, depending on which study you're looking at. And we have now an FDA-approved agent, capmatinib, also called Tabrecta, which you can use and you can prescribe today, and it is more effective than some of the other drugs we tried to use. There were a couple of FDA-approved drugs out there that had a little bit of activity against MET, but had been FDA-approved in other diseases because they weren't designed to target MET. They were designed to target something else, and kind of like their side effect was that they hit MET. And so we had been using a few drugs for these patients like that, but they weren't great in that situation. But now we have good data with Tabrecta, and then tepotinib, SIM015. These are also drugs that are pills. They work against MET, and it's almost as if MET is the new ALK, where we're having lots of drugs coming out in the space, and patients are going to have choices. Physicians are going to have choices, and this is really important because when one drug doesn't work for you or has a side effect, it's really good to have another option. I had the opportunity to talk to a patient who was being treated overseas. And in his country, they only had the availability of one drug for ALK. And after he tried that drug and it seemed to help a little bit, but he had a little bit of liver toxicity from the drug. And my initial response was, well, what's the problem? We've got 5 others. Just take one of the other ones. He said, no, in my country, we only have one. And so we had to go through a whole process to try to get him access to one of the other drugs that are out there. And so I think this development, this fact that, we've got pharma kind of piling on, and when one company comes out with a drug against a target, 3, 4 other drug companies just kind of pile in and they do the same thing. This is great. It's only a benefit. Well, we see med in both men and women. And the great thing is, when you look at the response curves with these drugs, you're not seeing hardly any patients whose tumor grows on these drugs. These drugs are making tumors shrink. And really the question then becomes not, will it work? Because the answer to that question is almost always yes. The question really is just how long will it keep working? And what can we do as scientists to try to make that duration of response longer and longer?
I think one of the positive kind of offshoots of all these new approvals and new targets is the generation of new oncogene groups. So we've known about the ROS1ders and the EGFR resistors and ALK positive for some time, and they're doing great things. And now, because of these new drugs and new options, we're seeing the MET Crusaders, we have the RET Renegades, we have KRAS Kickers, we have the N-Trackers. So all these new groups are coming to the table and having a voice and having a seat in the discussion about how they can help inform more research, better outcomes for patients, how they can help transform clinical trials. It's a boon, I think, for the lung cancer research community that as we have more survivors, there are more voices who can advocate for improvements. And, this will continue to just pay off for the community.
Yeah, I wish I had a thumbs up button for that, because I couldn't agree with you more. And just to take a break before we jump into RET and just kind of explain, because I know we've talked about a couple of different biomarkers right now, and I think we've also discussed how these tend to be smaller subsets of the overall population. But what I want to make really clear is that we're finding pieces of the pie, if you will, that are filling up an entire pie. So we're really looking towards how do we fill up that pie, figure out what is driving these types of cancers, and then what sort of drugs do we need to help target what's driving them. And again, not to beat a dead horse about how long I've been kind of doing this and watching it, but there was nothing. There was no pie pieces to be had that had targets when I first came into this. When lung cancer first entered my life back in 2003, there was a couple of things in studies, but there wasn't really anything approved yet. So the strides that we have made in what is a fairly short period of time when we're talking about cancer research and discovery is phenomenal. So that's why I wanted to give a thumbs up. Okay, RET. RET is next on the list. So what do we have going on there?
Well, the challenge with KIF1 RET alterations is the drugs we had available, which again were these drugs that weren't really designed to work against RET, but we kind of used them against RET, hoping it would have some effectiveness, led to really short responses. So, the patient's tumors would shrink, but they would only stay shrunk for a short period of time. Now we have 2 new trials, one called Libretto 001 and the other trial called Arrow, looking at 2 different drugs, selpercatinib and one other agent that really, again, these drugs really work. They target RET very effectively. They knock out RET very effectively. And so we're getting into a situation where people with RET alterations are almost assured that if they go on one of these drugs, their tumor is going to shrink.
And I think one of the important things that I sort of recognize in this space too, because it's not always the case with at least some of the early targeted therapies, was that it is showing promise and effectiveness in the brain as well, right?
Mm-hmm.
Yes, and that's very important. These drugs do cross the blood-brain barrier, and so it's really wonderful when you can have a patient and say, well, you know what, you don't necessarily need to have brain radiation. These drugs have a very good chance of controlling the disease even within the brain, and so having that as an option, as an alternative, is also just terrific. Again, something we didn't have not that long ago.
So true. I think that was always a big struggle because lung cancer, particularly in late stage patients, tends to like the brain, right? When it comes to metastases, and not having drugs that were able to pass what you referenced as the blood-brain barrier posed a very real challenge to a lot of patients. So it's some of the most exciting thing I know for the patients that I talk to that do have the brain metastases at diagnosis. So now I want to jump into KRAS. So there's been a lot of buzz around KRAS, over the last year or so. I want to talk about the prevalence of KRAS in non-small cell lung cancer patients. I also want to speak to the fact that we've been talking about the non-small cell lung cancer buckets so far. We're going to talk a little bit about squamous and small cell in a few minutes. But what's going on with this KRAS, specifically in G12C, as it relates to treatment options?
Well, KRAS is probably the biggest bucket, and the bucket that we've knew about for the longest. Roughly a quarter of lung cancer patients will have KRAS alterations, and KRAS alterations are particularly common in people who had used tobacco products. KRAS has always been thought of as undruggable. And we never, in the first 10 years of the development of targeted agents, could never find a way to target KRAS effectively. And the very exciting thing that happened, last year was that AMG 510 was announced. And this was a drug that was developed by Amgen and worked not against all KRAS, but worked against a very specific KRAS mutation, the KRAS G12C mutation. And that development was just so exciting because we didn't really have anything before for these people, aside from chemotherapy and immunotherapy. Now KRAS patients do benefit from immunotherapy. They're one patient group where I kind of get to double dip now. There's targeted agents available, and there's immunotherapy agents available, and having both of those is just terrific. But we're going to see a lot of activity around KRAS, and this is sort of one of the great things that happens in science, where when one person kind of figures out how to do something, and then everybody else looks at it and goes, "Oh, well, that's how you do it." And now I think we're going to see lots more KRAS drugs. And so we have Merida Pharmaceuticals has come out with a KRAS drug. And the really exciting one is we've got agents that have come out from Boehringer Ingelheim that target an upstream protein that works with RAS called SOS. And the great thing about that drug is that it's going to work with all the KRAS mutations. We don't think it's going to be restricted to a particular subtype. And that's really going to be important here early on before we have a dozen drugs out there on the market for KRAS. And I do think that, before I retire, we're going to have a dozen KRAS drugs. But between now and then, I think the access to these KRAS drugs is largely going to be in clinical trials. It's largely going to be at academic centers. And it's always harder to find a drug for you if the drugs are much more specific, where they don't work against all the KRAS, just against one particular subtype. So I think we're gonna go from KRAS being one of the hardest lung cancers to treat to being one of the easiest lung cancers to treat, but it's just going to take time. And so for those people out there who are listening, who may have KRAS alterations, the name of the game is to do everything you can to stay as healthy as you can for as long as you can, because new drugs are going to be on the way, and staying healthy so that you can have those new drugs when they're available is going to be very important.
I think that's a very valid point and an opportunity for me to point back to the clinical trial space in general, right? And how important it is to participate in clinical trials, because sometimes it is the best option for you. I mean, we're talking about, and everything we're talking about today is really talking about personalized or precision medicine, where you aren't just throwing spaghetti at the wall to see if something sticks. We're actually looking at your cancer. What does your cancer look like? What's currently available now, either in approved therapies or what is potentially in a clinical trial. To your point, Dr. Nieva, and some of these exciting things that are coming up in KRAS. I want to switch to squamous for a second. And for those of you watching, in non-small cell lung cancer, adenocarcinoma is the most common, but then we have squamous cell carcinoma. And so historically speaking, these patients are not biomarker tested. But we're starting to see some exciting things happen in this space. And doesn't mean that they don't have some of the, or they can't have some of the biomarkers that you can find in non-small cell lung cancer, which gets a little bit more complicated. So I'll let Dr. Nieva explain it. But I want to focus mostly on, PIK3 and CA and how what's happening in this space and why this is an important space for discovery, the squamous cell patient.
And I just want to clarify one thing, Danielle. Just because historically we didn't test squamous patients doesn't mean we shouldn't test the squamous patients. I think the squamous patients should be tested every bit as much as adenocarcinoma patients are tested, because sometimes the histology is just wrong. And it turns out, though, that really was an adenocarcinoma. And some squamous patients do have oncogene drivers. They'll I can tell you the times where I said, oh, should I test this person? They were squamous. This was kind of early on. It's like, oh, they had an EGFR mutation. I had a patient recently come in who had a NUT fusion with squamous histology, and that's something for which there's drugs in development for. So we need to test everybody, and I think I can't say that enough times. There isn't a subtype of lung cancer that shouldn't get tested. But moving on to what we can do for patients with squamous tumors. Of course, the biggest thing is something we're going to get to later, which is immunotherapy, because immunotherapy in squamous tumors works very well. On the targeted therapy side, when we're looking at small molecules that are going after specific proteins driving the cancer, we have PIK3CA, and there was a little bit of data on PIK3CA that came out of ASCO, but these are still very early days. It's clear that when there's a PIK3CA alteration, it's usually not the only thing that's driving the cancer. We're going to have to learn a lot more about that driver and kind of how it works and how it interplays with everything else before we really have good treatments for it. I don't know. What do you think, Amy? Was there something that you wanted to add about that?
No, I think you did a good job summarizing it. And, I agree with your key point, which is more testing across, the whole space. I think that's the common denominator here. And the most important takeaway from the science that was presented at ASCO is it all reinforces the importance of timely, comprehensive biomarker testing. And that's something that we are definitely committed to and will be working hard to deliver as part of our kind of revised strategic plan going forward.
Yeah, and I just want to reiterate that this is another spot where I wish there was a thumbs up button, because we are speaking the same language about squamous cell patients and biomarker testing. So I feel like there's a sound bite coming our way from the comment that you made. I want to touch on something really quick, and then I want to jump into immunotherapy. I want to be mindful of time and make sure we get into the COVID and lung cancer conversation, because I know that's a big concern for a lot of folks in our community. The thing I want to touch on is that, we know that in spite of all of these exciting things happening in the targeted therapy space, there's still a problem with resistance. So we did want to let you guys know that there are a lot of studies going on looking at resistance, and equally as important to that is another opportunity to reiterate the biomarker testing and retesting, if you will, at the time of resistance. Because what the scientists and the researchers and your physicians need to know at that point is what is causing your cancer to become resistant to the drug you're truly on. So I just wanted to let everyone know that that is something that is a hot spot. And it is happening. Studies are happening across the board in that area. I don't know if quickly, Dr. Nieva or Amy, either of you wanted to touch on resistance and anything especially exciting that you saw coming out of ASCO before we move on to IO.
Sure, I can jump in and just, briefly remind folks that, GO2 is working with ALK positive on a novel study looking at combination approaches to ward off or prevent drug resistance for ALK patients. We know that, eventually resistance occurs. And so can we hit tumors hard early on up front with combinations of or smart combinations of approved drugs. And hopefully, as I always like to quote Dr. Bavona, he and Dr. Christine Lovely are the co-PIs of that project, as he says, we don't want to interrogate the black box after the plane crashes. We want to keep it from crashing in the first place. I think that's a great metaphor for what we want to accomplish in this space. Can we, beyond just the individual targeted therapies, can we do combinations to help solve the resistance challenge that we know is out there?
Thanks, Amy. That's actually a great segue into the conversation around immunotherapy and some of the combinations that are happening in the IO space and some of the information coming out of that. If you guys want to jump over into that bucket.
Yeah, again, great data coming out of ASCO this year on immunotherapy. And it's around the same theme of now there's more options. We had data presented confirming what everybody already knew, that when immunotherapy works, it tends to work for a very long time. And so anyone who's been blessed to have an immunotherapy response really has had something very special happen. And then we had data from the Checkmate 9LA trial, which showed that a little bit of chemo mixed with the immunotherapy makes the immunotherapy work better. And I think we already knew that from the previous studies that Merck had presented, combining chemotherapy with their immune therapy drug. But now there's more ways to do it. Now you can give a little more immunotherapy and a little less chemo, or you can use different immunotherapy drugs. The Caspian trial was presented, which again gave us a few more options in terms of things that were out there for using immunotherapy. So, I don't think we took away anything from ASCO that was different in terms of what we had learned, but we now said, well, we don't have to do it this way. We can do it a bunch of other ways as well.
I think that's great. Amy, do you have anything to add?
No, I think combinations, again, are showing great efficacy for patients, and particularly in the small cell setting. So, that was something that we haven't really touched on at length, but we are now seeing the, emergence of new options for small cell patients with immunotherapy. And so that's encouraging as well.
Couldn't agree more. It's such important stuff and important work. Is there anything else before we jump into COVID and lung cancer that you guys want to say or touch on or close out about ASCO?
Everybody's still working. So even though people are working from home, they're still working. The clinical trials infrastructure at many universities is still up and running. So it's still possible to get on clinical trials. And who knows, if you go on a clinical trial next year, they'll be talking about you at ASCO next year.
Yeah, it's still a very rapid pace that's happening for lung cancer. And, so many advances and new approvals have come out this year. And, things look different because of COVID, but that doesn't mean our work has stopped. Cancer hasn't stopped. Our commitment to lung cancer patients has not waned. I think people are more committed than ever, recognizing the challenges that patients face. So, you have not been forgotten. You are not alone, and there is great reason for hope in spite of, what's going on around us.
Thank you, Amy. Now I want to jump into and let you sort of take away the conversation, Amy, around COVID-19 and lung cancer, and recognizing that this is a sensitive topic for our community, right? There's a lot of concern around all these things and the whispers, or not so whispery things that are coming across the news about comorbidities, or diseases you might have and or be living with, that really, if you were to contract COVID-19, could be a really big problem for you, lung cancer clearly being one of them. And I know at ASCO and at AACR, like I said earlier, you've been paying close attention to that. So I'm going to kick it off to you and let you take it from there.
Yeah, I mean, this is a space where, I have this weird combination of skills to bring to the table, being trained as a virologist and then as a cancer scientist, and winding my way to the lung cancer advocacy community. But, the positives, and we like to think about silver linings, is that, COVID has brought the lung cancer advocacy community closer together. We recognize the threat that this virus presented to lung cancer patients early on, and as a result, GoTo Foundation, Longevity Foundation, the Lung Cancer Research Foundation, Lung Cancer Foundation of America, we all came together to provide, weekly updates to the community, so we could be kind of a single source of vetted scientific information to, again, educate and empower the community with the information you need to protect yourselves and to make the best decisions that you can for your own care and, for those around you. And so we've been doing that since March 3rd. We have 2 abstracts that have grown out of that work that are being presented as posters at the AACR COVID-19 and Cancer Conference that I'm actually attending this week. We have seen the development of several large registry studies which are looking at the impacts of COVID on lung cancer patients. And the numbers are scary, and there are caveats. So one of the studies that we've heard about is the TerraVault Consortium, and then there's the CCC19 registry study, and then there's been some more recent cohort studies that have come out of the US. Some people said, well, maybe things look different than they did in the TerraVault registry study, because that was more European based. And we know that because of the acute nature of the pandemic there, that some patients were triaged out of treatment, and maybe their outcomes will look different had they received access to, ICUs and ventilators and so on and so forth. What I can tell you is that of the number of studies that are out there do seem to be worse outcomes, and mortality is elevated. But, from the study reported by researchers at Memorial Sloan Kettering, that seems to point to patient-specific risk factors rather than necessarily the type of treatment that patients are on. There's still some debate about, whether IO confers worse outcomes or chemo confers worse outcomes. But the good news is that I think the lung cancer community is coming together to understand further the risk of COVID-19 for our patients. They're coming together to mobilize research to understand the nature of the immune response mounted in these patients. We are part of a large grant that's being submitted tomorrow, in fact, to really look at the immune response in lung cancer patients. So, as scary as it seems, there is a lot of hope. There are silver linings. The data that was presented by Memorial Sloan Kettering, there was 20% mortality at the height, but even patients with severe disease and late stage cancer did recover. So I don't want people to assume that this is a death sentence should they be diagnosed with COVID. That being said, we want to encourage patients to take all the precautions that we continually recommend for the general public: social distancing, hand washing, wearing a mask. These are things that all of us can do to keep ourselves and our loved ones safe. And it makes added sense for the lung cancer community in particular, given the increased risk that seems to be emerging from the studies that we've seen thus far.
I think it's so important. It's important information for our community to have. And I think, one of the other pieces to this, or one of the other layers to this, is the social isolation, right? Particularly with our community, who might be more afraid, even with all that proper PPE and hand sanitizing, they might be more afraid to go out at all, even if it's just to the grocery store. And I think we at GoTo recognize that we have several different ways that we can kind of help alleviate some of that, whether it's through the meeting like this, through our social media platforms, through Health Unlocked, which is our patient community platform. We have options for you, so please don't hesitate to reach out to us. And all of this information is available through our helpline, which I know we've been flashing up on the screen throughout this program.
I
Yeah,
would be
Amy.
remiss if I didn't point people to the lung cancer registry, where we have done some unique enhancements to track patients longitudinally with their baseline, annual, and quarterly surveys. As many of you know, we want all women with lung cancer to come and participate in our sexual health assessment of women with lung cancer, or SHAL study, that's being led by Dr. Narjus Duma. That's critically important for, quality of life for people who are living with lung cancer. We have lung cancer survivors, and that's a fantastic, testament to the power of research and where we are today compared to when you started all this, Danielle, just a few short years ago. So please go check out the Lung Cancer Registry, and just know that we are here to be a resource for you on all things, and you are not alone, and there is a lot of reason to have hope.
Thanks, Amy. Dr. Nieva, any closing thoughts?
I just want to thank the GoTo Foundation for the support that they give academics and patients. It's always the place that my patients can rely on to get up-to-date patient materials and other information.
I want to say a special thank you to those who may be watching who have participated in clinical trials. It is because of patients like you that these discoveries are happening. I know for a lot of people, clinical trials sound like a scary space, but I can assure you they aren't your grandfather or even great-grandfather's clinical trials. So thank you from the bottom of all of our hearts in the lung cancer community. Thanks, everybody. Have a wonderful rest of your Tuesday.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.